Hey fellow lab rats, this is Rebecca from the Lab Rat YouTube channel. In this video, I'm going to be giving you an introduction to hemolytic anemias. All right, let's get started. The word hemo means blood, and lytic or lysis basically means breaking down. So hemolysis or hemolysis means the breaking down or degradation of red blood cells. Normal red blood cells survive in the peripheral bloodstream for 120 days. So what happens to them after they are at the end of their lifespan? They are largely removed by macrophages in the spleen when, of course, they get older. The heme and globin portions of the hemoglobin molecule are separated. The heme portion is divided into iron, which is recycled, and the porphyrin rings, which are eliminated from the body as bilirubin. The globin portion of the molecule is broken down into amino acids. So this is a normal process. When red blood cells get old, this is how they are destroyed. Now, when this process is accelerated, so when the red blood cells are lysing before that 120-day period, that is when there is an issue. The red blood cells are created in normal amounts, but they, for whatever reason, have a survival defect and are lysed prematurely. The red blood cells are getting destroyed quicker than the bone marrow can create and replenish them in the peripheral bloodstream. So this is hemolytic anemia. Now, in vitro hemolysis is where the lysing of the red blood cells is happening once the blood is removed from the body. So this is due to improper blood collection, or if the patient is a hard stick, the red blood cells can lyse when being drawn into that specimen tube. If the specimen tube is exposed to extreme temperatures, the red blood cells can break open. Also, if it's stored for a prolonged length of time, the red blood cells can lyse. So a picture of a hemolyzed specimen is on the right-hand side here. So you can see that the serum is red in color. This is caused from those red blood cells lysing. So this does not mean that the red blood cells are doing this in vivo, meaning in the body. This is an in vitro scenario. So this is happening within the tube and is actually quite common. Hemolytic anemia is an abnormally decreased red blood cell count and/or hemoglobin level caused by the breaking down of the red blood cell. Erythrocytes or red blood cells, of course, live in the peripheral bloodstream for that 120-day period. When they are lysing before that 120-day period, this is when the hemolytic anemia occurs. So this is a premature destruction of those red blood cells. We already know from our other anemia lectures that the bone marrow is going to do everything it possibly can to try to compensate for this premature blood loss. So there's going to be an increase of red blood cell production in the bone marrow to try to compensate for that red blood cell loss. At some point, the destruction of the red blood cells is going to overcome the amount of red blood cells that bone marrow can produce, and it can no longer compensate. We'll talk a little bit more about this in the coming slides. There are various classifications of hemolytic anemia, and most of the time extravascular hemolysis occurs, but intravascular hemolysis can also occur. And again, we'll talk about those two terms coming up here. So not all abnormal hemolysis will result in anemia. And the reason for this is because of the bone marrow. So the bone marrow is going to do everything it possibly can to try to compensate for this premature blood loss. So again, there's going to be an increase of red blood cell production in that bone marrow to try to compensate. And again, also, at some point, that destruction of those red blood cells is going to overcome the amount of red blood cells that the bone marrow can produce, and it can no longer compensate for it. So the bone marrow can ramp up production by 8 times the normal amount. It will churn out as many red blood cells as it possibly can to try to compensate for the loss. Unfortunately, in certain cases, the red blood cells just cannot survive long enough for that bone marrow to be able to compensate. And this is when the anemia in the patient starts to show. So I mentioned that there are various classifications of hemolytic anemia. They are classified based on the source of the anemia and what defect is occurring. In these classifications, we differentiate between whether the anemia is intrinsic or whether or not the anemia is extrinsic. So I'll discuss those terms momentarily here. We also look at how the hemolytic anemia developed. So what triggered the onset? So was it something that was inherited or was it acquired? And then, of course, we classify hemolytic anemia based on where the hemolysis or the destruction of those red blood cells is occurring. Is it intravascular, meaning happening within those blood vessels, or is the red blood cell destruction happening extravascularly, which is outside of the vessels, like in the spleen? So let's talk about the terms intrinsic versus extrinsic. I mentioned in the last slide that hemolytic anemias are classified based upon if they are intrinsic or extrinsic. That's one of the factors of what we classify hemolytic anemia as based on. So intrinsic is when there is an issue with the red blood cell itself. So it's the red cell itself that is the problem that causes it to be destroyed prematurely. This is usually genetically predetermined, but not always. Extrinsic is basically the opposite of intrinsic. So it means that there is nothing actually wrong with the red blood cell. It's something in that red blood cell's environment that causes that red blood cell to be prematurely destroyed. So this is usually acquired, meaning it isn't genetic, but that isn't all of the time. So some exceptions to these rules are two disorders. So the first one's called paroxysmal nocturnal hemoglobinuria, and the second one is called avitalipoproteinemia. So paroxysmal nocturnal hemoglobinuria, or PNH, is an acquired disorder that causes an intrinsic issue within the red blood cells, which causes the hemolysis. PNH patients experience sudden recurring episodes of hemolysis, which can be triggered by stress or infections. Avitalipoproteinemia is a rare genetic disorder that causes low levels of certain lipids. It can also cause fat malabsorption, which can lead to vitamin deficiencies that help to potentiate the destruction of the red blood cells. Hemolytic anemias are also classified based on whether or not the red blood cell destruction is occurring inside or outside of the blood vessel. Patients with hemolytic anemia will experience anemia when their bone marrow can no longer compensate for the red cell loss. So their red cell and hemoglobin levels will be decreased. When red blood cells are destroyed, the hemoglobin is broken down and eventually becomes bilirubin. So when there are a massive amount of these red blood cells prematurely being lysed, there's going to be an increased bilirubin in the blood. This can cause something we call jaundice, and jaundice is a yellowish or greenish pigmentation of the skin caused by a high bilirubin level. All of this hemoglobin being prematurely released is also going to cause something called hemoglobinemia, which is free-floating hemoglobin hanging out within the plasma. Hemoglobinuria, which is hemoglobin present in the urine. This will also be present if the patient is experiencing an intravascular hemolysis, so hemolysis occurring within the blood vessels. Splenomegaly, which is an abnormal increase of the size of the spleen, can occur when there is extravascular hemolytic anemia happening. And this is because those red cells are being destroyed in the spleen. When there are massive amounts of those red cells coming to the spleen and getting destroyed, it's going to cause that organ to become enlarged. Cholelithiasis is the condition of having gallstones. So this can occur due to a disturbance in the production of bile. So what things are we going to see as laboratory professionals in a patient that has hemolytic anemia? So there's going to be an increase, of course, of red cell destruction. So we're going to see an increase of bilirubin. Of course, remember, when red blood cells are destroyed, that hemoglobin is broken down and eventually becomes bilirubin. So when there are massive amounts of these red cells being prematurely lysed, there's going to be an increased bilirubin in the blood. There's also going to be an increase of lactate dehydrogenase, or LD, present in the bloodstream. So LD is intracellular. It's present within the red blood cells. So when they break open, that LD is going to be dropped into the bloodstream. And I talk a lot about LD in clinical chemistry. Obviously, there's going to be a reduced hemoglobin, hematocrit, and red blood cell level on the complete blood count. We're losing red cells, so we're going to have a decreased RBC and H&H, so that makes sense. So when hemoglobin is released into the bloodstream, when the red blood cell lyses, hemoglobin gets picked up by something called haptoglobin and forms a complex with it. So if we have a ton of extra hemoglobin being released from the lysed red blood cells, there's going to be a lot more haptoglobin binding to it, and therefore the amount of free haptoglobin in the blood is going to decrease. Because of all of it is going to be bound up by that extra hemoglobin hanging out in the bloodstream. And there's also going to be an increase of urobilinogen. And so just like bilirubin, urobilinogen is created from the breakdown of hemoglobin. So that's going to be increased as well because we have a massive amount of red cells getting prematurely lysed from this hemolytic anemia. I feel like a broken record here talking about anemia, but it's very important to understand these concepts. The body's going to do whatever it can to compensate for the loss of the red blood cells. So it's going to increase erythropoiesis within the bone marrow. So what will we see as medical laboratory professionals in the peripheral bloodstream of a patient that has increased red blood cell production? So an increased reticulocyte count. So reticulocytes are part of the erythroid lineage. So they're the cell just before they become mature red blood cells. So a small amount of these are normal in the peripheral bloodstream, just in normal situations. They come out of the bone marrow into the bloodstream, then quickly become mature red blood cells. So if the bone marrow is increasing the production of red blood cells, it's going to have more retics, and more retics are going to be pushed out into the peripheral bloodstream. There can be a normal MCV or slightly increased MCV value. Again, those retics are going to be a little larger than a mature red blood cell, so the MCV values of the peripheral blood may be increased. Nucleated red blood cells may also be seen in the peripheral bloodstream. This is for the same reason that they're going to be reticulocytes. These are immature red blood cells, and that marrow is churning out these as quickly as possible to try to compensate for the red blood cell loss. So it's throwing nucleated red blood cells and reticulocytes out into that peripheral blood. There can also be an increase of white blood cells and platelets. Intravascular hemolysis is when the premature red blood cell destruction is happening within the blood vessel, so within the circulation. So if we have a ton of extra hemoglobin being released from the lysed red blood cells, there's going to be a lot more haptoglobin binding to it. And therefore the amount of free haptoglobin in the blood is going to decrease because all of it's going to be bound up by that extra hemoglobin hanging out in the bloodstream. When red blood cells are destroyed, the hemoglobin is broken down and eventually becomes bilirubin. So when there are a massive amount of these red blood cells prematurely being lysed, there is going to be an increased bilirubin in the blood. Urobilinogen is also created from the breakdown of hemoglobin, so it will be increased. All this hemoglobin being prematurely released is also going to cause something we call hemoglobinemia, which is free-floating hemoglobin hanging out within the plasma. Hemoglobinuria, which is hemoglobin present in the urine, will also be or can also be present. There may even be hemosideruria, which is the presence of hemosiderin in the urine. This will stain blue if the urine is stained with a Prussian blue stain. This slide is basically saying the same thing again. I feel like a broken record here, but this concept is very important. So the red cells are prematurely lysing within the circulation and releasing hemoglobin. It gets picked up by haptoglobin and forms a complex, and this complex gets cleared by the liver. So this is why haptoglobin is decreased in the blood when hemolytic anemia is happening. It's complex to the free hemoglobin. Once the haptoglobin levels are decreased enough, hemopexin steps in, and it binds to the hemoglobin. So after the liver has a greater than 5 milligrams per deciliter of the complex in it, this leads to hemoglobin in the urine. And once it has reached the tubular reabsorption level, hemosiderin is sloughed in renal tubular epithelial cells and is shed in the urine. So this is why we'll see hemoglobin and hemosiderin in the urine with intravascular hemolysis. So all this is happening with intravascular hemolysis. So what causes intravascular hemolysis? So there can be a complement activation of the membrane of the red blood cell, there can be damage to the red blood cell, or there can be toxins that are present in the circulation that causes the lysis of the red blood cell. All right, now extravascular hemolysis. So remember at the beginning of the lecture when I was talking about hemolysis, I said that hemolysis is a normal thing when done at appropriate quantities. So this is how old red blood cells are destroyed and removed from the body. It's only an issue when too many of those red cells are being destroyed. So 90% of the normal red blood cell destruction is happening as extravascular hemolysis. The macrophages in the spleen of the body recognize the red blood cell abnormalities, or in a normal case, that those red blood cells are at the end of their lifespan, and degrade it to heme and globin. Heme is degraded to biliverdin and iron. The iron is recycled and the biliverdin breaks down into bilirubin by an enzyme called biliverdin reductase. It then binds with albumin and is taken to the liver for further degradation. So what happens to cause abnormal extravascular hemolysis? There could be a couple of different reasons. So enzyme and membrane defects of the red blood cell that are inherited, some acquired defects, and then immunohemolytic anemias. This is an antibody-mediated process. The red cell is recognized and is taken to the spleen to be prematurely destroyed in extravascular hemolysis. So I'm going to be discussing a lot of the hemolytic anemias in detail in the upcoming lecture videos. Of course, this is just a summary or introduction to what hemolytic anemias are. To give you an idea of the types of defects that cause hemolytic anemia to occur, I've broken down intrinsic and extrinsic issues that can cause premature hemolysis to occur. Recall, intrinsic means that there is an issue with the red blood cell itself, whereas extrinsic means that there is a problem with the red cell's environment that causes the hemolysis to happen. So intrinsic, again, is usually inherited and causes extravascular hemolysis. These can be caused by membrane defects of the red blood cell, certain enzyme disorders, and abnormal hemoglobin. Extrinsic is usually acquired and causes intravascular hemolysis. These can be caused by destructive factors in the plasma, traumatic injury to the red blood cell, or an immune-mediated destruction of the red blood cell. And again, I'm going to be discussing all the different hemolytic anemias in upcoming lectures, so please check those out. Alrighty, if this video helped you, go ahead and give it a like, and please make sure to subscribe to my channel for more educational laboratory content. Alrighty, have a nice day. Until next time.